Hi, my name is Joe Perfetti. I'd like to welcome you to the Duke CE LinkedIn Live event, another episode of the Agile Dashboard. This is a show that's focused on what's next, because we at Duke CE are dedicated to getting leaders ready for what's next, and the Agile Dashboard brings the latest thinking from global leaders forward to discuss how they apply the concepts of the Agile Dashboard in their organizations to navigate uncertainty and to seize opportunities. Today, our very special guest is Dr. Steve Evans. He's the EVP of Medical Affairs and the Chief Medical Officer of MedStar. He will be our guest. He oversees a medical education, research, clinical quality, and risk management initiatives for the system, as well as their academic partnership with Georgetown University's School of Medicine, as well as other MedStar Health academic affiliations. And for everybody's benefit, MedStar is about a $5.7 billion net patient revenue system with 10 hospitals in the Maryland, Washington, D.C. area. It has an academic partnership with Georgetown. It has over 30,000 associates and 5,400 affiliated physicians that are in Dr. Evans' network. Steve, welcome to the show.
Thanks, Joe. Great to see with you today. Great to be here.
Joining me today, I will have two panelists, which will join us in a few minutes. We have Beth Ehrling, who is the Regional Managing Director of Duke CE Europe. She runs everything pretty much in Europe globally and is an expert on leadership. I also have Dr. Scott Coher, who's a professor, vice president, and vice dean of the Geisinger Commonwealth School of Medicine. He runs their graduate school, and they will be joining us for additional Q&A. I'd also like to remind those of you watching us live on LinkedIn as well as on YouTube, if you want to ask Dr. Evans any questions, please put those in the chat. We will be looking at those throughout the show, and you'll have a chance to participate with your questions and comments. And then after the show is over, you're welcome to see the replay at the Duke Corporate Education LinkedIn Live page. But in the interest of time, we got a lot to talk about, Steve. I want to start out with the 30,000 foot view, the big $1 million question. How has COVID changed not only MedStar, but the business of healthcare?
Well, I think it's had probably one of the most dramatic impacts, certainly in my lifetime, of an event in a 4 to 5 month period, Joe. So first piece up, I would say, like MedStar Health, many healthcare systems were somewhere on a trajectory for systemness. And I say that systemness piece of going from multiple hospitals that are in a holding company pattern where they work independently to a really fully integrated healthcare system, one common financial platform, one common clinical platform. And so what COVID-19 did was really accelerate that systemness effort, and certainly did it on ours as well. And I'll give you some examples of that. But I think the full integration requiring people to work across a healthcare system and thinking about how they manage their resources, whether it's supply chain or whether it's personnel, to manage the crisis, every organization had to accelerate its systemness efforts.
Well, and I applaud the word systemness, because there was an article that came out this week from McKinsey that basically said organizations that focused on Agile tended to do better in crisis. And obviously your systemness journey has probably prepared you to be more Agile. So can you give an example of how systemness allowed you to start pivoting during the crisis of COVID-19?
Yeah, so the McKinsey definitions are sort of definitions we live and die by, I think, from our perspective. So we've been working at this for now about 12 years to become an integrated system. So a good classic example is during the crisis, we put out about 160 communications on various clinical pathways that were required to manage the patients. When it came down to specifics around ICU care, for instance, on nuances, we had one integrated ICU service line across our system. We had leadership that was in place that reflected the knowledge and experience of everybody in our ICUs. We didn't have to go to 10 separate ICU teams within 10 separate hospitals and have a conversation around how we're going to do this. It made it an awful lot easier. We also had, even from our quality and safety perspective, we had one full system platform that allows us to really think through how do you deliver care better, How do you manage ventilators better? How do you make sure that you can distribute remdesivir to COVID-19 patients better? Not at one hospital, but across non-acute care hospitals or across a bigger healthcare system.
So I imagine during the surge that came, particularly for you, probably in April in the DC region, there must have been a bed crisis. Did the Systemness help you with that?
In a huge way. So, and again, it gets back to what has changed in healthcare. So we have about 2,400 beds across our system. We had two intense hotspots within the state of Maryland, Montgomery County and Prince George's County. Those two counties made up half of all the entire cases within the state of Maryland. We have two of our hospitals, community hospitals in those places. And so we actually built out significant surge capacity in both of those hospitals, and then actually created what we call the MedStar triage office and a triage officer that created one virtual bed for the entire system. So we could actually load balance and move patients around based upon either acuity of care or capacities within our ICUs. We increased our ICU capacity pretty significantly, but this whole MTO model of actually moving patients and load balancing based upon real-time data made it incredibly, well, nothing was easy during COVID-19 crisis, but it made it easier in terms of managing the volumes of patients coming into smaller hospitals, moving them into our bigger hospitals where we had greater capacity.
Yeah, load balancing is something you think about in the IT world. It's interesting how you've applied that to the beds. I also imagine in the world of IT that, basically telehealth had to become very important to you during this process as well.
It did, and we had a pretty good infrastructure for telehealth. We had a whole MedStar Telehealth Innovation Center, MTIC, that was in place that was really building out multiple use cases. We had an urgent care e-visit platform that was in place. But the real crisis came when all of a sudden patients could no longer come in for ambulatory visits. So, and lots of patients needed healthcare and needed to connect with their physicians. So did a pretty extraordinary thing. Our Innovation Institute built out in 7 days an entire ambulatory visit platform with almost 200 people, lots of tech type folks to build out the platform that allows us to see almost 4,500 patients today on the virtual visit platform. So it was a classic case of Agile. We moved really fast. We brought in the appropriate resources. We had incredible leadership that could build it out quickly and execute it in a very fast fashion.
And I know we had talked about this before this session, but just so our audience understands, you were averaging 2 daily visits for telehealth before COVID-19.
Yeah, small number. I mean, we were single digits for sure, and had lots of interesting use cases, but they're almost all in single digits. This exploded really quickly, and in part because patients still needed to see their physicians and follow up, and they needed connections, and they needed to discuss their histories with them. And so to make sure that we could continue to keep them connected, we built it quickly, and it exploded. I mean, the number of physicians was over 2,000 at one point utilizing the platform, and again, over 4,000 visits a day.
So you rolled the system out in a week. Could you have done this if you weren't a $6 billion system of 10 hospitals?
So it's interesting. This was on our roadmap. So we had just finished a whole strategic plan related to what we wanted to do for the last 10 years. We were completing it. It was MedStar 2020, and we were looking now for the next 5 years where we would need to be. And this telehealth platform was really a critical piece of our whole digital enterprise. And the plan was to build it out in 3 years, built it in 7 days.
And I also think that part of this was also the e-visits for the prompt care clinics as well, which were those minute clinic-like things for the people that may not know that your brand is called Prompt Care.
Yeah, so the MedStar e-visit piece was, we actually had in place. It was in partnership with a third party with Amwell. And so it was highly successful, and it was for the usual kinds of things that you would need for sinusitis and flu-like symptoms. But during COVID, we really exploded it. We brought in a whole lot of providers, about 250 that actually served to sit on the platform to manage it. We had at one point seeing over 500 patients a day on that platform. The advantage of it, that coupled with our urgent care sites really was the front face during the pandemic, during the peak of it, that allowed us to triage patients either to our urgent care sites, to our EDs, or to other areas to get tested appropriately versus just flooding our emergency rooms, which never happened.
So I think leadership is a very important word. And so in the middle of all of this, as a leader, how did you manage this? What were some of the lessons learned that you could share in sort of this kind of, quick scaling up in the middle of a crisis that you could share with the listeners?
Well, I would say that it's really good to have a leadership capability where you don't need much more than 2 to 4 hours of sleep per night for I think that helps. One of the biggest and most interesting challenges, which I didn't anticipate, and all of our leadership experienced it, was the information overload. So we were about 3 weeks behind New York City. And so as we saw our numbers going up, you can just characterize this as information. And we had direct lines of communication with Mount Sinai, with Northwell, with New York Presby, with NYU. And so we had lots of information being channeled to us from multiple connect points with them. We also had CDC doing literally 8-hour updates on their website on what needed to be changed or modified based upon either patient protective equipment or testing or you name it. Then we had specialty societies from around the country, you name it, American College of Surgeons, Society for Critical Care Medicine, doing regular updates on what they thought was the best practices and approach. And then you had everybody else on social media. So those 4 channels, I was flooded, as was my entire team, with information on a regular basis as to how to manage and triage all the info so that we could then get it back out to our people in terms of what was the appropriate and best practice to manage. I would say from a leadership perspective, having an incredibly talented team that can run hard and fast, I think this was a classic example of servant leadership. The first thing we said is, we are going to do everything we can to manage our patients, but we are going to do everything humanly possible to keep our people safe. And so we had thought through that well in advance. It's our tagline. It's how we treat people. So we spent a lot of time in advance on making sure that we had patient protective equipment stored in advance so that we would not run out. We would not look like New York City. We had ventilators that we had purchased well in advance. But I think on the leadership side, it was classic servant leadership for our people. And then heavy amount of it has to be top down. But it also has, if you're going to do that, you also need to allow, and it's the oxymoron. If you're going to do heavy top down in a crisis, you need that, but you also need creativity at the point of care. So here are the guardrails within which our nurses and docs worked, and then they got really creative, and we allowed that creativity to figure out how best to manage these really sick patients, because the white paper on how to manage a COVID patient had not been written yet.
And therefore communication must be really key. How did you communicate with such a large network of physicians and nurses?
So we ran big calls. So I sit as the incident commander and as the chief medical officer for the system. It was a little bit easier for me because I had direct line of sight for everything clinical within the organization. So we ran calls 7 days a week, every day, with 450 people on the call. 19 operational leaders that covered the entire organization operationally. Again, it's Systemness, so we had one person speaking for the entire organization in the 19 operational areas. That can include laboratory, pharmacy, you name it. And then everybody else, all the leadership from each of the hospitals, our ambulatory sites, our VNA, our research enterprise, everybody reported out. We did 2-hour calls on a daily basis, and then continued to maintain this whole thing called COVID-19 Now, which we pushed out, that had all the updates on the numbers, the metrics, the communications that we pushed out. We had one behind a firewall and one in front of a firewall so that it was easy for anybody on their phone to pull up anything they needed at any given time.
And so I imagine the communication and connectedness now extends to people that unfortunately are now suffering from the surge that's happening in the South, Florida, Texas, Arizona, California again. Are you guys working with them now?
We are. So people at Banner Health have reached out to us, people that are down at USC, University of South Carolina, people at Emory. I think there's a pretty broad-based connected network. It's one of the great things about being in great healthcare systems. The network is pretty tight. And so I think a lot of the lessons that we had that occurred in Seattle, that in New York City, I think hopefully people are better positioned in terms of managing it going forward.
Yeah. Well, the other part of it is on the business side of healthcare is, and I've experienced this myself, is that, I know half of your revenue approximately came from outpatient services. What happened to them as a result of all the COVID-19? Where'd the patients go?
Well, I think, like you saw everywhere, early in March, the second week of March, all elective surgery was canceled, all elective office visits were canceled. And so for a lot of the staff that we had, we redeployed them into other parts of the organization. But, there was hundreds of millions of dollars. Our system is not unique, hundreds of millions of dollars lost in overall revenue. And so I think now we're at a point where if you looked at the first week of May, Joe, we were sitting at around 550 COVID patients in our hospitals, 200 on ventilators. We're now down to in the low 120s. And so we've got a little bit of breathing space and are trying to stand back up now all of our elective surgeries and ambulatory visits and are slowly getting back on those numbers. But it's a crawlback. I mean, this is the biggest financial crisis in American hospitals history. And it's going to take time to recover.
Well, and it seems like, you're very, very data aware, which is really critical in this crisis to understand the data and to use it as leading indicators. I mean, this show is called the Agile Dashboard, and I very much appreciate this. What's on your dashboard? I know you shared a couple of items, and if we can get our producer to pull one up, but what are some of the key things that you're looking at on your dashboard to help you as a leader?
So this is our an e-visit dashboard. It's interesting too how we built this. So we have an enterprise data warehouse. It included one for COVID. We integrated everybody, quality and safety data a team, our PI data team, our finance data team. We had everybody in to create our dashboards. And so on this, it was really looking, if I take it to the upper right side, where are the calls coming from? We wanted to look at geography. It gave us a sense of if the numbers were getting bigger on individuals who are symptomatic, it gave us a sense of where the hot spots were going to be in our region. It also gave us a sense, it's interesting when you look at this, I'll take you to the middle on the patient experience piece. You can see the average provider rating at 4.9 on a Likert scale of 5. We always joked about it. I think our patients in the midst of this crisis enjoyed more being on a telehealth platform than seeing our physicians in person. But the tracking of how they viewed it became important. We also looked at the data on what the wait times were, and you can see those down in the right-hand corner. And then the total cumulative numbers that you can see up here on total visits and average daily visits. All of these metrics, I think, became really important for us. It also became important in terms of where we distributed our providers. You can see the total number of providers that we've used as 275 on that platform, currently using 39. So the data helped drive where we used resources, where we thought hotspots would be, trying to stay ahead of it. But we're a pretty data-driven organization, and our enterprise data warehouse proved to be really useful during this crisis.
No, and again, I applaud what your team was able to do here and with some of those other eBed and virtual stuff that you've done. By the way, I also want to, I don't know if the word is congratulate, but say thank you, because I heard that you're about to hit the 3,000 mark COVID discharges.
Patients. So we were at 2,970 something. We'll break through 3,000 within the next 3 or 4 days. But 3,000 COVID-19 survivors in our hospitals discharged home to their families to celebrate holidays, vacations, birthdays. It's an extraordinary, and it's just a tribute to the incredible care for our nurses, our physicians, respiratory therapists.
Well, all I have to say before I go any further is thank you. I mean, tell your team, tell your associates, thank you, and repeat that. It is just amazing what they do and what you continue to do. So in terms of audience questions, I know we actually have a couple of ones, and I see one here from, I'm going to pronounce the name poorly, Tokazil Mara, who just basically asked about measuring effectiveness. So you have a lot of data about how many people you're seeing, how many people you're treating, to some degree physician scores, but like what tells you that you're being effective?
So on our enterprise data warehouse, from a daily perspective, we knew the number of admissions of COVID, we knew their length of stay, we knew their survival rates, we knew case fatality rates that we calculated, we knew the number of patients on remdesivir, we tracked all of that data to see whether or not we were getting better. we also looked and tracked the number of patients who were converting. So we would see how many patients were testing positive. So in the pandemic, we were at points of where 25% of every patient we were seeing was testing positive. Now we're down into the low single digits, well below 5%. So it gave us some leading indicators that proved to show where we were moving. And I also think the number of patients that we were testing continues to go up. So from a population health perspective, the more testing we were doing, we felt the more effective we were being in managing our ability for our population. Since I think you saw it, we were at one point, we were managing 1 in 4 patients who were hospitalized across the system. So those kinds of data points, I think, Joe, helped us determine whether we were being effective on managing and also on testing and triaging patients within our region.
Well, I know you referenced that McKinsey study. I mean, when any of us are talking about Agile, you have the communication, you have the connectedness, you have the empowering of the team, you have the ability to pivot. I mean, it's almost like you've done a lot of things right with that systemness view. So I would like to bring in Beth and Scott to join the conversation, ask some questions as well. But I see another question from Nikki Mullen in the audience I'd like to ask you, because it was one thing was on my mind as well, which is just before Scott and Beth ask you, basically I'll paraphrase, but like as an individual leader, you know, how do you survive this? I mean, the stress level on you and your organization must be immense, and it's not ending. It's going to continue. So what can you say as a leader?
So it's a really an important question. I think we stayed very realistic with everybody on our calls. So as the numbers continued to go up, we assured people that these were big numbers, but we had capacity and we had prepared for this. So I think the other part is we train and do exercises every year with the entire organization on major emergency preparedness. And we live in a unique geography, Washington, D.C., the Baltimore-Washington corridor. And these exercises that we did were, catastrophic events that would occur in our region. And we had all of our leadership team involved in these exercises. I think for most of our leaders, I think that they characterize this as their moment. This was what we have trained for. This is what we have prepared ourselves for. And it was interesting, too, because I made rounds in all of our hospitals during the middle of the crisis. And I'll never forget talking to one of our physician assistants in our ICUs at one of our community hospitals that was literally had gone from a 12-bed ICU to now a 30-bed ICU in a period of 48 hours. And I was asking him, I said, so how are you doing? Because we had moved him from one of our sites down to this hospital. And he looked at me, he said, Steve, this is what I've been waiting for my entire life. And I think for many people in healthcare, this is how they would define their moment of greatest need and their ability to give back and to do what they have been trained to do. And so I think for many people, this was their moment of a lifetime to actually do what they can do best and do it at the highest level and perform at the highest level possible. So I think one part of it was being realistic. The other part is being inspirational. It also helps. I'm a surgeon. I can run on 2 to 4 hours of sleep a day for a long, long period of time. And we did that. And I think that helps. And being surrounded by really talented people that are much smarter than you, that can run as hard and as fast as you for as long as it takes. And so I think those are certainly some of the leadership lessons.
Hey, Beth, I see you nodding your head. And I know you guys have been hit pretty hard across the pond in the UK. Just thoughts for Stephen, any additional questions you'd like to ask?
Yeah, absolutely. Dr. Evans, thank you so much for what is an absolutely incredible story and picture of resilience. And I really particularly loved your description of servant leadership in this context. And I know that is something that many leaders are grappling with, that we speak to at this time, of what types of leadership behaviors. And I'm particularly interested in the micro routines that you might have found have helped you and your teams be most effective and resilient in the face of incredible stress. So I'd be particularly interested to hear a few of those. Love to hear about the daily touchdown. I know many organizations have found that or renewed that at this time, but what else did you find really helped?
We got into some, so it's a great question, Beth. We got into some very clear patterns. So 8 to 10 every morning, big system calls, 450 people, everybody tightly connected, tightly scripted, used all 2 hours. And then after that, it then launched. And then it launched into the clinical sub-teams meeting, hospital leadership team meeting, nursing leadership meetings, the chief medical officer meetings. And so there were, each of the groups spun off out of this. I would say, I think everybody in our organization understood one very clear thing. And I think everybody put egos aside. This was legitimately about servant leadership at the extreme, because I think people understood all the efforts we were putting in were to keep every one of our associates safe, which was no small task. And I think trying to deliver the best care possible. And so there was no ulterior motives. There wasn't anything else. We kept it high level. We kept it aspirational. And I think people responded in a very, very strong fashion to the challenge at hand.
Yeah, and Scott, I know you do a lot of research on agile teams. I mean, this is like the clinical definition of an agile team. So.
Absolutely. Well, Steve, my thanks as well for your leadership and for all the care your teams are given in the community. So I'm so impressed with the description of what you're doing for your workforce. The complexity of healthcare and your workforce, though, I think is often lost unless you're a healthcare insider. So you've got interprofessional healthcare teams. Each of these team members is expert. Would you talk a little bit about everything from patient handoffs to coordination of data to the outcomes that have to be shared across those interprofessional teams? Highly complex, highly difficult when we're not in an international pandemic.
So it's a great question, Scott. I'll give you the most extreme example, though. In the midst of this crisis, we created new teams. And so from a redeployment perspective, we actually brought in ICU nurses from other hospitals in our system and other critical care physicians and other respiratory therapists, and created new teams where we actually had to expand surge capacity. And the assimilation was unbelievably seamless. And I think part of it was because when we had that in place, everybody now had a playbook. So we had a very clear idea, and everybody had at their fingertips on their phones the playbook of exactly how we did proning, how we gave remdesivir, how we moved ventilators and drips and drugs and lines outside of our ICU spaces so that there were fewer times into the rooms, so that the playbook was really clear. So when people jumped into the space, they clearly knew their roles and responsibilities. But the greatest thing, and again, I think we're a great organization, but people go into healthcare for one reason. I mean, this is service. And so when people jumped into the new space, they didn't know their other team members. They came in with open arms and they were loved and adored. I mean, the assimilation was so fast. And we had lots of examples of new team development. The other thing we had a luxury on is we created something called IMOC, Interdisciplinary Model of Care. We had started it 5 years ago. It was true interdisciplinary rounding teams on med-surg units and other places. And so our nurses and physicians were used to having respiratory therapists and our pharmacists and social workers and folks making rounds collectively together. So a lot of it was done on virtual rounds, given the need for physical distancing, but people felt really comfortable in team structure, managing our patients and making rounds.
And Steve, you continue to amaze me what you guys have been able to do as an organization, and agilely as a healthcare. It's not what you would expect. I always assumed healthcare was slower than academics, and we're pretty darn slow. And you're the exact opposite. So applause on that. But here's an interesting question. What's next for healthcare longer term? And what has fundamentally changed now as a result of COVID-19 that's going to be an enduring change in your mind? And I know you guys also focus a lot on population health at MedStar, because Maryland's one of the leading states in the country to drive that. So what's going to start changing for you in the future?
Again, I think COVID-19 escalated a lot of things, Joe. I think it escalated telehealth. So the platform for telehealth is here to stay. I think that from a payer-provider perspective, and telehealth is going to have a bigger role. It was playing big in lots of areas: behavioral health, teletriaging in our emergency rooms. But I think it's going to continue to play bigger and bigger. And I think there's a lot of patients who don't want to have the inconvenience of trying to park at a hospital, would rather be seen and evaluated on a telehealth platform or for post-operative visits. So I think it's here to stay. I think it's going to be an integral part of the care delivery model. The other part of that, I would say, that's going to change is going to be this whole piece of systemness. Organizations, I think in this crisis, realized that they could be really effective working as an integrated unit across multiple hospitals, and I don't think they're going to want to give it up. And I think so from the old classic McKinsey model of being a pure holding company to a full integrated delivery care network, I think people got a taste of it if they hadn't had it before, and they're not going to want to go back. And so I think that's going to change it dramatically.
And also, I know you guys are using the word care pathways. Does that play into the systemness role going forward?
It does. And so you want, even within our medical group, we have, we're now at about 2,500 employed physicians, 1,000 APRNs. And so across that, having integrated service lines that have one voice for how you do a care pathway model, whether it's for ICU, critical care services, or hospitalist medicine or ED medicine, but having one unified care model, independent of where you come into any hospital, that it looks exactly the same, and having good standardization around that without suppressing innovation, I think is really the holy grail for what systemness looks like.
Yeah. And technology, I assume you guys are pretty tech savvy. Is it even higher up the priority list?
Well, there are financial constraints in the setting of this crisis, Joe. So I think everybody wants more technology and they want bigger, broader digital platforms for connecting to patients. But this is a pretty financially constrained model. I would say this, some of the most interesting and creative and innovative thinking comes in the setting of significant financial constraint. When you got a lot of money at hand, creativity goes down the drain. People just spend it. I think when you have less money, and that's where the world of healthcare is right now in the United States, people get a lot more creative. They get a lot more innovative. And so I'm not trying to be Pollyannish, but I am pretty bullish on the idea that we're going to be much more creative in the next 5 years.
Well, you've been pretty creative in the last 5 months.
We've had amazing leadership with great people to be able to execute like this.
I know we're coming to the end of our time. Scott, Beth, any final questions for Steve?
I've got a quick one, Steve. You've talked about a number of different, if you will, tools. Are there additional sense-making devices that you've installed or relied upon to help people think through this systemness, this interconnectedness that you're talking about? Anything that are the routines that you're doing with your leadership teams?
I would say that data does drive behavior so much, Scott. So I think we were early on into building out our enterprise data warehouse. This escalated it. This brought in lots of talent from different parts of the organization. So I think that may be a place where it becomes much bigger, much stronger. So the data side of the organization drives our behavior in a different way, whether it's clinical or financial.
You also mentioned your purpose, healthcare leaders coming in, you just know what you're doing. It seems like you've been able to operate, not skip a beat, but in fact, accelerate.
We certainly accelerated a lot of pieces of the organization. I think we were poised to do this. We were also caught at a really interesting inflection point because legitimately we had our large, big leadership team retreat in February. Our first admission for COVID was on March 7th. And at that meeting in February with our leadership team retreat, we were just looking at MedStar, what do we look like in the next 5 years? And we were all deep into a whole strategic planning process. And so I think that kept people energized, and I think this crisis may have accelerated many parts of that.
Yeah. Well, stay healthy. That's great.
Thank you. Thank you.
Yes.
All right. Well, again, I think we're unfortunately at the end of our time here, and I know you're very busy today, Steve. So I again can't thank you so much for not only doing the show, but what you and your team have been able to do with not only the COVID-19 patients, but just in general. And somebody who lives down the road in Maryland, again, appreciate everything. So thank you so much.
Thank you, Joe. Thank you. Thank you, Beth.
And again, thank you, Scott and Beth and the audience as well for joining us. And also just want to say thank you to Duke Corporate Education for making this broadcast possible. And if you'd like to learn more about any of our research or more about what Steve has been talking about, and as well as about the Agile Dashboard or our Building Strategic Agility course, the link is below. You can also go to the Duke Corporate Education website and get some additional information on some show notes and some references that we're talking about here today. And as we go forward, again, stay safe, have a great day, and remember, you can't drive a car looking in the rearview mirror. Look forward to seeing you next time. And again, Steve, thanks for being on the show.
Thanks so much, Joe.
Thanks so much.